Good afternoon, everyone, and welcome to our fourth and final session of today's Target Pulmonary Embolism Connection Forum. Thank you to those who've been tuning in since 11 o'clock today. It's been a fantastic day hearing insights from our outstanding speakers across the country so far, and we hope you've enjoyed the sessions as much as we have. I'm Alexa Cohen, a program consultant at the Heart Association and your host for today. As mentioned, this event is made possible through the American Heart Association's Target PE initiative, supported by Inari, now part of Stryker. And on behalf of the American Heart Association, I would like to introduce our last session, Strengthening PE Care Pathways Through ED Relationship Building. This session will explore how strong partnerships with the emergency department can enhance PE care pathways. And our two speakers are from OhioHealth, and they'll be drawing on real-world experience and discussing strategies for effective education, ongoing relationship building with ED leadership and clinicians, and the use of clear algorithmic approaches to reduce variability in care. With that, it is now my pleasure to welcome our last, but certainly not least, two speakers of today's event, Sara Anderson and Dr. Justin Morrison from OhioHealth. Sara is an advanced heart and vascular clinical program coordinator with over 25 years of nursing experience and is also a member of the National Blood Clot Alliance Medical and Scientific Advisory Board. Ms. Anderson specializes in process improvement and program development for cardiovascular populations like PE, STEMI, and cardiogenic shock, and leads initiatives aimed at improving early recognition, care coordination, and timely intervention across both hospital and ED settings. Joining Sara, we're also excited to welcome Dr. Justin Morrison, a board-certified interventional cardiologist and endovascular specialist at OhioHealth. Dr. Morrison's expertise lies in peripheral vascular disease, and he's actively involved in delivering comprehensive advanced heart and vascular care to patients in the greater Columbus, Ohio area. As a quick reminder to our audience, please make sure to send in any questions you have at any time throughout today's presentation, and we'll review the questions during the Q&A at the very end of this session. Sara and Dr. Morrison, with that, the floor is all yours.
Thanks, Alexa. Good afternoon to everyone. We're excited to come and share with you what our team has experienced through the years dealing with the emergency department and building relationships. I will tell you that as you're trying to build a VTE program, the most important thing you can do is start with that ED relationship. I would say at least 80% of our patients are all going to come through the ER, and that is really an intake where you need to look at where these patients are coming from and start with that in your process. So I'm going to talk a little bit about us so you can understand kind of what we're dealing with. We are OhioHealth Riverside Methodist. We are a 1,200 bed, we're actually quaternary teaching hospital. We have 16 hospitals in our system with 7 freestanding ERs that also funnel into us. We primarily have interventional cardiologists that specialize in vascular doing our PE care. That's within 5 cath labs. We have 2 hybrid ORs where we do complex procedures. We are the only cath lab in the state of Ohio that has 24/7 on-site 4-member CVL team with a second backup team that also has 4 teammates. We've been doing comprehensive venous work for over 20 years. With that being said, how did we get started? To be honest with you, we were doing all the initial trials with Inari, within heart and vascular, at least in the cath lab. We knew what we were doing. We knew what the complex cases looked like when we were doing catheter-based things, and we were really aware of it. Unfortunately, nobody else in the hospital was aware of it at the time. So what really started jumping off and started our ED relationship is that I actually got an email from our ED associate medical director, and he said, "Sara, we have an issue I think we really missed on this patient." Short background on the patient. They had come in with a syncopal episode, and none of our team got consulted, nor did we know about the patients for 13 hours after the CT. In the meantime, the patient had PEA arrested, was on pressors, and was pretty sick by the time someone called us. So when we talked to the ED, we knew our care was fragmented, but the big thing was that they didn't know who to call. They did not know about catheter-based care. We did. There was a huge knowledge gap about the urgency and what we had with advanced treatments, and we knew that we needed to kind of get a multidisciplinary approach, and our ED partners were the ones that kind of helped us initially get this off the ground because of the barriers they had. So, you know, when we started looking this from an ED perspective, the big thing they wanted was an easy button. Everybody wants an easy button. You need someone there that is going to be that point person. When we started talking to the ED about these discussions, they said, well, what about the STEMI coordinator? At the time I was a STEMI coordinator, I had all the same relationships. They knew me already, and it became quite clear to our team and our physicians at the time that we would leverage that position to help build relationships with our ED. They were all the same stakeholders and all the same goals, and at our facility for the appropriate patients, we chose to treat these PE patients that needed thrombectomy just like STEMIs. So we knew we had to standardize that care, remove the bottlenecks, and kind of look at how we can improve patient outcomes. So through this role, the ED identified stakeholders that needed to be in collaboration with our interventional cardiologist. One thing they said we were missing was real-time feedback and resources. They wanted to look at data. They wanted to implement process change and drive this protocol development. These were all things that none of us in the cath lab were aware that the ED actually wanted. So when we first started this collaboration, it was really crucial to identify those physician champions. We had physician champions from the ED and the cath lab that were highly involved in some difficult conversations, really saying, hey, we kind of screwed up here, or this was a missed opportunity. And just like the case I mentioned earlier, it's really important that you don't shy away from those uncomfortable cases, because those uncomfortable cases will help you kind of push your objectives and be able to further your program because you can identify data that supports it. So how do we start? Obviously, you can ask 10 interventional cardiologists the same question. They're going to give you 20 different answers based on the patient. So where we decided to start was really communicating. I'm going to tell you right now, when I travel around the country and talk to other facilities, the reason why programs don't get off the ground is because they're not communicating enough. I cannot emphasize more how important it is to communicate. And that will actually build your foundation for success. So after building and identifying the physician champions, it was really important for us to sit down with the ED and say, who are you dealing with in the ED? They touch every single specialty in the emergency department. Who are they having issues with? What were their experiences with other specialties when dealing with PE? Getting this whole gamut of people together that we can also build a foundation to help forward the program. So first things first, obviously you have to cast a wide net. This is the other thing I see where you have a failure to communicate. Obviously, in our process, the VTE coordinator was going to be that person in the center kind of assisting all the physicians. And obviously the ED interfaces with all these departments. And that's why your relationship with your ED has to be strong, because they touch every single specialty. So I am going to tell you, you can never cast a wide enough net. Let everyone know. And then from that point on, if someone doesn't need to be involved or on the need to know basis, then you can shuttle them off into a different category and let them know as things progress. So we chose to break this down into phases. I am a firm believer that if you are not doing things slow and methodically, you're going to miss things. And that way your process improvement is going to have some gaps in it at some point. So in the discovery phase, I went downstairs with 5 of the ED leaders, all physicians, and said, what are your barriers? Tell me what's going on. We whiteboarded it. We had old-fashioned Post-it notes, and really looking at how the ED patients came in and what phone calls the ED physicians were making to try to decide how to take care of this patient. They didn't have any guidelines on high risk, low risk, who to call. The appropriate lab work wasn't being drawn. We weren't seeing a lactate. And so there were a lot of bottlenecks in care. One of the first things we identified was that it was taking way too long to get a CT. When you had somebody with a syncopal episode, a high PESI score, they weren't even aware of that. So those bottlenecks kind of highlighted patterns that they were seeing and things that we had to identify in that discovery phase. Through that, we then looked at streamlining the process for the ED, making intake changes based on the captured data, in process and protocol development, we started with the ED, then you move on to other areas where the patients come in. But after that, we really went into implementation mode, putting the protocols and process change into place, and then monitoring and reassessing. I cannot encourage you enough to continue to reassess. When you don't reassess, your program becomes stagnant, you miss opportunities to improve. There's always ways to improve. A big thing too, which I think some people and who have been in healthcare a while notice, is that, you have to have a realistic timeline. A lot of times when you get an exciting new thing, something that's going to bring money into a facility or something that people are really excited about from an administrative level, they get a very unrealistic timeline of how things should occur. I would say to you to stand strong with your physician champions, be very realistic in your timeline, and make sure that it's slow and steady and that you have patience with the evolving process. So just to show you an evolution of protocol development, this was the first protocol that we developed with our multidisciplinary team. Obviously, the ED and our cath lab physicians were leading this. We also had input from heart failure, critical care, and CT surgery. All of these people had input. I'm going to tell you, this is probably one of the things that took the longest when we initially started, because there are a lot of different opinions. So, but eventually you will get there. Current state, this is the new system PE algorithm that has been approved by our system heart and vascular team. I just want to reiterate more of always changing. When we focused on this, we have, as I mentioned earlier, a lot of other hospitals that filter into us. It was very important to start to focus on them with early recognition of PE patients and early treatment. As I reviewed system cases, this is the next opportunity we identified, is how we were getting notified about these patients, and not to let them sit at other facilities for 24, 48 hours without knowing the correct treatment protocol. So obviously our hospitalists, our APPs, it's very important that they understand the process. The other intake area that we focused on was our transfer center. Again, when we went to the transfer center and started to talk to people, same issue the ED had. You have a referral physician that's asking to talk to a critical care doc. You have a referral physician that's asking you to talk to a surgeon. It was all over the place with how these PE patients were coming in through the transfer center. So once again, we got the team together and put together this diagram on who should be called and when, making sure that the transfer center could get the right patient to the right physician so we could expedite care. Whether that was, hey, the patient's fine, let's just anticoagulate, we think they can stay at your facility, or hey, we need to do a rapid transfer. Another ED process that came out of this was that, we needed to do an ED to ED transfer. The problem with those, and as our ED medical director likes to say, they are the largest inpatient unit in the system. So bringing people into that ED atmosphere, we had to really sit down with them and say, hey, we guarantee we're going to come down and look at the patient. We're going to give you a plan. If the patient would deteriorate, we're going to take them emergently to the lab. So all of this kind of built together with how we're bringing patients in was really crucial in kind of getting the word out there about how we need to treat PE patients. So realistically, in phase 2, it really was, let's take care of your own house first and make sure everybody within OhioHealth Riverside knows about our PE program, knows who the key stakeholders are, and knows how we want to treat these patients, more that we want to know sooner rather than later. Internally, they needed to know who the point person was. So that was me letting people know what we were doing. We also initiated a 24/7 on-call phone for our PERT team that took them directly to our interventional cardiologist that was on call. During the day, that would go to our PV APP that was rounding with that physician for quick access to them. There needed to be a single point of contact, an easy button for anybody within our hospital that was concerned that they had a patient with PE. Realistically, when that would happen, I would offer resources to go talk to nurses, talk to staff, talk to APPs, just really someone out there letting everybody know that we've developed a program with the ER. This is what we're doing. Now we need your assistance to make sure that patients don't fall through the cracks. With that was ongoing data to support the need for coordination when we wanted to bring more people in. Let data just build that story when you're talking to people, and building the timeline when there are issues. The same thing we did with that first patient that was really not comfortable to talk about, but needed to be talked about to really enforce change. With that follow-up, I'm going to tell you a picture's worth 1,000 words. I don't know if any of you have heard people talk about clot hall, but these are one of the ways that we would let our ED partners, our critical care partners, the floor, anyone who had touched that patient know about their patient and what the outcome was. I will tell you early on, we would, if the ER physician could leave, he would come up into the cath lab after we were done. We would literally show them the clot. This is free marketing for your program. This is the easiest way to get communication about your program, show them the patient outcome, and really get everybody on board to kind of think PE. So when you get to phase 3, you now have your data. You have everybody know, or you have your data points, excuse me. You have the data points you want to capture. You have your team in place. Now it's time to really do the work. And sometimes the work gets uncomfortable. Real-time case review with our entire PERT team. Initially, that was every couple of weeks. We'd get cases, and I would try to identify areas that we had opportunities from the ED and cath lab perspective. We would identify the team ownership and how to evolve using that opportunity on a case-by-case basis. We made it a point, I did, to celebrate milestones whenever we had an ED team that really did a great job, or a cath lab team, really trying to give your team those kudos, because all of you know, 9 times out of 10 when you're in a hospital, the emails that coordinators, physicians, administrators are getting is when there's a problem. We really needed to celebrate the strengths and look at that opportunity for growth and really bring our team along with us. And when we peeled back the onion, you know, we all had to learn how to play nice in the sandbox because everyone has separate opinions. So I'm going to tell you, this came from one of our PV doctors, Dr. Phillips. And if you are looking at trying to strengthen your ED cath lab relationship, I'm going to encourage you to kind of keep this and look at it and how it pertains to where you're at in your program right now. Managing complex change is difficult, especially if you have a culture that's been a certain way for a very long time. So having a vision, you know, what are we trying to do? We are trying to build a PE program to expedite PE care. Having the skills, you have the operators there, you have the coordinator that can help. Having the incentives, for us, the incentive was really expediting care, meeting our ED partners where at their area, which their incentive was really that they needed to get the patients out of the ER. Having the resources to do that. In our situation, we went ahead and jumped off of my STEMI coordinator position. One of those things, I know that FTEs are hard to get sometimes, but is there a resource within your facility that you can help do that? Is it getting an FTE, or is it using another position that's already integrated within your ED? And having an action plan, having phases, communicating with everybody about how you're going to do that. So, you know, the biggest thing I see is that people don't stay the course. They don't have a strong ED cath lab relationship where they can go to administrators, they can go to other people within the hospital and stand and have a united front. It's very important to have that group. Start with that ED relationship and really find out what their barriers are. Understand your culture. If you're newer, find someone that's been there for 25, 26 years like myself, or a physician, and find out what the culture really looks like, why you don't do certain things, why you do certain things. Change is always going to be challenging. So just keep it simple, be very strategic in what you're trying to do, don't do too much. Um, Build those multidisciplinary relationships. Don't silo yourself. The siloing will kill a program rapidly. And I'd say the big thing is stay patient focused. Whenever we're trying to implement something, and if we get pushback, if it's a patient care and safety issue, say it's a patient care and safety issue. Really keep that patient in the center of everything you were doing, and you will find that it will be much easier to implement different changes within any type of culture that you're working in.
Thank you so much, Sara and Dr. Morrison, for an amazing presentation and model share. I think it's so great to see how OhioHealth has leveraged such a strong relationship with their ED and just improving your PE workflows and overall care quality. We now have some time to take a few questions from the audience for our speakers. So if anyone thinks of anything, feel free to drop them in the Q&A. But the first thing that we wanted to ask you guys was, you really spoke about kind of casting a wide net across stakeholders and how important communication is in starting both a PE program and also just building those relationships with the ED. What specific outreach or engagement strategy do you think was the most effective in getting ED clinicians and other teams to buy into the program and communicate with each other, building those relationships early on?
The big thing I feel like was actually asking them what their barriers are, not going in with our own agenda, but what are you facing, and how can we help you? You can't go down and say, we need you to do this, we need you to do that. How can we help you? And they're really one-on-one conversations. In this day and age, I feel like people like to send emails. Our physicians are overloaded with emails. Really taking time to go down and introduce yourself and ask, how can we help you? Justin, I don't know if you have anything to add to that.
No, I think that's probably the most important aspect. And, in the beginning, it's obviously extremely important, but even now, after so many years, continuing to re-engage ED physicians. And as you saw in the beginning, we're a very large system with 16 hospitals, multiple freestanding. There's a lot, I think there's over 100 ED physicians in their group. There's a lot, there's natural turnover. People who are starting may not know what our culture is, or they came from a place who didn't have a similar culture or maybe treated PE differently. So, from a physician standpoint, it's just as important to us as continuing to re-engage all those folks, from a physician level all the way down to anyone who has any piece of the pie. So we continually meet with multiple physicians and physician locations to keep that relationship strong and just to let them know what capabilities we have. Even after all these years, we get new hospitals added to our system, and they may just not know that we have such a nice PE program, DVT program that we can help their patients with.
Yeah, definitely.
Yeah, Alexa, I think the other thing is that, and Justin touched on new physicians. So our physicians are contracted out and work for Mid-Ohio Emergency Services. They have their own branch of communication and meetings as well. So depending on who your physicians work for, it's really important to identify those people that can also help reiterate in meetings, process change, introductions, and things that you might need to get the word out about process and program changes.
Yeah, no, definitely. Thank you both for those responses. That's incredibly insightful. I think touching on like some of like different changes in a system, new physicians coming in. Did you guys experience any challenges in kind of building that trust, or when new team members do come in, how do you build that trust and kind of overcome that in the communication and relationships that you are having with these teams?
Yeah, I think from a physician standpoint, it's, as Sara mentioned, it's just being transparent and honest. We are somewhat aggressive in treating PEs at times. And, again, they may have been at a prior place or trained at a location that may have taken a more conservative approach. And so, from our standpoint, we, try to engage them right away. Obviously, we're talking to them in real time. When a consult comes out, we're available 24/7 for any level of PE. And then, I think follow-up is really important. So Sara showed you the document she makes still to this day for every PE we do in DVT. But I also, the age of EMR we have Epic. I can directly message those physicians. I can let them know, thank you, for giving us a call. This patient did really well. Talk about hemodynamics, how they're feeling. And I just think it's that positive reinforcement after. And, sometimes things don't always go well, and you just have to let them know, like, we feel we did what we can, and, the patient's in the ICU and is, just is in critical condition. So I think for all the new physicians that we deal with in ED, and it's really on almost a daily basis, new faces are coming in,
Mhm.
names I don't recognize, is just, educating them in real time on what we have to offer, and letting them know how their own patients did.
Like, thanks for touching on that. We did have a few questions just come in from the audience. The first question we wanted to ask is, are there any specific algorithms that you guys use, and how have you adopted them when it comes to PE and everything?
Yeah, I think all of our algorithms are based on the guidelines. Obviously, we have some newer guidelines, and some of the language will likely change in what you saw there, since the language has changed on the most recent AHA, ACC multi-society guidelines. So that's where it all starts with. And then, we've been lucky enough to have some really nice trials over the past few years, and we can incorporate that data into our algorithm decisions. Outside of that, up until more recently, when a lot of literature has caught up to the clinical need, it was based on early experience from my predecessors, with Sara when she started the program with some of the retired docs. And those experiences kind of went into where we may place a patient based on the risk, and being able to utilize that objective data in real time and in real clinical situations to help differentiate where they need to go and if they're a candidate for catheter-based procedures. And then one last thing is we review all of this data. So we look at, I mean, Sara obviously knows what procedures we're doing, but from a physician standpoint, we look at their objective information, troponins, what did their echo show, what was the ratio. And if we find that maybe we're being a little too aggressive over a period of time, we'll review that, and that may be incorporated into our system-wide algorithm.
Yeah, thank you so much, Dr. Morrison, for answering that question really well. Another question from the audience, do you have a specific PE call line with EMS specifically?
I will let Sara take
No,
that one. Yeah.
yeah, no, we don't have a specific call line for EMS. I will tell you, about 4 or 5 years ago, we started doing PE outreach with our physicians, excuse me, basically telling them to think PE. If you're in the back of the truck, have they had a long, trip? Have they had a surgery? Is one leg more swollen than the other? So what we really encouraged EMS to do was tell a good story, because that will take us down a treatment algorithm when they get to the ED. So more of education about the awareness of PE. So now we do have EMS encoding saying, I think we have a possible PE, instead of just giving us, well, they're short of breath.
Got it, got it. Thank you so much, Sara. Thank you for
Mhm.
answering those questions. And thank you again to both of you for your amazing presentation. Unfortunately, we're getting close to time, so I just wanted to thank you guys again and the audience for their participation. With that, this concludes our Target Pulmonary Embolism Connection Forum for the day. Thank you to everyone for attending today's event. We hope you found the sessions as helpful and as interesting as we did. And we encourage you to visit the Target PE Initiative website to learn more. You'll also be receiving a post-event survey via email with some questions to help us as we continue developing future education opportunities throughout this initiative. Again, thank you all for your attendance, and we hope you have a wonderful day.